Hello ladies and gentlemen, my name is Dr. Mervat Matar. I'm a professor of clinical hematology, Qasr Al Aini Cairo University, and it is a pleasure for me to be here to discuss relapsed therapies in multiple myeloma. These are my talk objectives. We are going to discuss the classification of relapsed multiple myeloma, the currently approved drugs, and how to choose therapy. Let us first discuss the classification of relapsed multiple myeloma, and these will include either high risk, intermediate risk, or standard risk myeloma. And of course, the standard risk probably will do better than high risk relapsed patients. With high risk, you need to point them out. These are early relapsed myeloma patients with less than 12 months after stem cell transplant, or with progression within the first year of diagnosis, or with cytogenetic abnormalities including deletion 17p, translocation 1416, translocation 1420. Intermediate risk group includes translocation 414 or 1q cytogenetic abnormalities, among others. With standard risk, you get all others, including trisomies, translocation 1114 or translocation 614. So as you can see, you need to make sure to pinpoint your patient and make sure if he is high risk, intermediate risk, or standard risk relapse. After discussing which type of relapsed patient you have, you need to look at the currently approved drugs and see if any drug would be better, for example, for high risk groups or not. These are the therapeutic options in multiple myeloma. These of course include the immunomodulators, including thalidomide, lenalidomide, or pomalidomide. They also include proteasome inhibitors, including bortezomib, carfilzomib, or ixazomib. They also include the monoclonal antibodies with elotuzumab, daratumumab, or isatuximab. And they include others, of course the backbone of corticosteroids, but there are others too, very new drugs such as pabinostat, selinexor, or even CAR T-cell therapy. This is as in contradistinction to the standard chemotherapeutic agents that were used in the past, including melphalan, bendamustine, vincristine, adriamycin, or cyclophosphamide, that may be tried in combination with the newer drugs. So these are the chemotherapeutic agents. These are the melanges that were included in relapsed multiple myeloma treatment. And as you can see, up front in the early 2000s, they used to use the doublets, whether a proteasome inhibitor with dexamethasone or the IMiD immunomodulator with the dexamethasone. And then later, as of the 2014 and then beyond, they started to use the triplets with the combination of a proteasome inhibitor, an immunomodulator, and the dexamethasone or others, so that you can achieve a better progression-free survival and a better overall response rate. Of course, this is in contradistinction to first-line therapy. And so, in 2012, they compared triple therapy versus doublets, and they enrolled patients either in a thalidomide dexa arm versus a Velcade thalidomide dexa arm, and they analyzed the responses. And let us look. The triple therapy patients fared better with a better progression-free survival in the yellow with the VTD versus the TD alone. Looking at the responses, responses were better with better complete responses and better VGPRs in the VTD arm versus the TD arm. And so the more the better, yes, but patients should have less comorbidities at relapse so that they can endure a triplet or even a quadruplet in relapse. Maybe they can do that in the first relapse, but in second and third relapse, this becomes more and more cumbersome. And so in treatment of relapses, you try to hit as hard as possible with the best option you have so that you have a second prolonged progression-free survival after response to first relapse, so that you can have a delayed second relapse and a delayed third relapse, and so on. So what about proteasome inhibitors? Now we have the first generation, the second generation, and even the third generation proteasome inhibitors. And what do? They act on the ubiquitination of the protein aggregates. And so these protein aggregates accumulate in the cell and kill the cell because the cell cannot get rid of them using the proteasome inhibitors. Let us look at the second generation proteasome inhibitor, which is called Kyprolis or carfilzomib. It is a permanent proteasome inhibitor, and it has been used in patients with relapsed multiple myeloma. Look at the ASPIRE study. They compared Revlimid Dexa versus Revlimid Dexa plus Kyprolis or carfilzomib. And as you can see here, carfilzomib was used in the 27 milligram per meter squared dose, and it was given for only 18 cycles, after which it was discontinued. Let us look at what happened in these cases. As you can see, KRD had a higher progression-free survival in blue versus RD alone in yellow. And this was very nice results. I have to point out that carfilzomib was discontinued after 18 cycles. And probably, as we now know, carfilzomib could have been added and continued for longer. I have to point out that this was statistically significant, better progression-free survival with the addition of Kyprolis versus RD alone. Looking at progression-free survival subgroup analysis, in patients that had only one prior line of therapy or 2 lines of therapy before, or even that had been exposed to bortezomib, which was the first generation proteasome inhibitor before, all fared better with the addition of Kyprolis versus RD alone. And so even in patients that were heavily pretreated or that had been exposed to a proteasome inhibitor before, the addition of Kyprolis, which is a second generation proteasome inhibitor, gave better results regarding the progression-free survival. How about the overall survival? Kyprolis extended the overall survival in addition to RD by 7.9 months versus RD alone, the line in blue versus the line in yellow. And this was also statistically significant. How about at first relapse? Patients that received Kyprolis Revlimid Dexa at first relapse fared better. As you can see here, the median overall survival was 47.3 months versus 35.9 months in the RD arm alone. And this was very nice. How about overall survival even in patients that had been progressed? Even the patients had been progressed, the overall survival was around 13.5 to 14 months in both arms. And so our benefit would be prolongation of progression-free survival. But once a relapse happens beyond, the overall survival is bad in both arms. How about patients that relapsed early or relapsed late? Of course, patients that relapsed late fared better than patients that relapsed early. But in both arms, in both patients, types of patients, the addition of KRD gave better results than patients with RD alone. How about the extension of progression-free survival, both in early and late relapse patients? Always the blue line is getting better than the yellow line. So even the patients that had an early relapse or in patients that had a late relapse, the addition of Kyprolis to RD fared better with better second progression-free survival after response to treatment. How about the quality of life? Quality of life was much better in cases with the addition of Kyprolis to RD versus RD alone, by many questionnaires asking the patients how they did. And so not only the survival was without progression prolonged, but also it was a good survival. The patients fared well regarding quality of life. Then they looked at the endeavor, which is a carfilzomib Dexa versus bortezomib Dexa. And here they are comparing a second generation proteasome inhibitor carfilzomib to a first generation proteasome inhibitor bortezomib in cases that were relapsed refractory. And look at the number. The number was 929 patients included. And here they included carfilzomib in the 20 milligrams per meter squared days 1 and 2 in cycle 1, followed by a dexamethasone together with in comparison to Velcade dexa. معلش أنا عايد الحتة دي تاني. Okay? Here the Endeavor study, which is comparing a second generation proteasome inhibitor to a first generation proteasome inhibitor in the relapsed refractory setting. So they are comparing carfilzomib dexa versus Velcade dexa in these patients. And look at the number of inclusion, 929 cases. Let us look at what happened. KD was much better versus VD regarding progression-free survival. The progression-free survival was extended by 8.2 months. So this was a very good gain of time regarding response after relapse. How about patients that had only one prior line of therapy? Yes, the KD extended progression-free survival by 12.1 months. That means that if you need to use carfilzomib, you use it early relapse rather than late relapse to give you even better results. How about in patients that had been receiving bortezomib before? Because now we are giving a second line treatment of either bortezomib again or a second generation proteasome inhibitor carfilzomib. And as you can see here, in patients that had been exposed to bortezomib before, still KD gave good results versus VD. And in patients that had been receiving lenalidomide before, this was also better with the KD versus the VD. And even patients that were renalid refractory, KD fared better than VD. How about overall response? Overall survival was better by 7.6 months with the KD arm versus the VD arm. How about patients that were relapsing early versus patients that were relapsing late? Well, KD fared better than VD in all cases of relapse. Even in early relapse, Kyprolis fared better than Velcade, and also in late relapses, Kyprolis fared better than Velcade. In both trials, relapsed refractory myeloma patients receiving carfilzomib-based therapy achieved higher rates of CR and overall response rates, regardless of whether they experienced early or late relapse. In general, patients with early relapse, of course, had lower response rates than patients with late relapse. How about patients that relapsed? What about the extension of progression-free survival? So, if patients relapsed early or relapsed late, they had a benefit of extending the progression-free survival with carfilzomib versus Velcade. As you can see here, the median progression-free survival was still 13.9 versus 5.7. And how about here in the other relapses, 22.2 months versus 10.2 months only in VD. And so, whether the patient had a late relapse or an early relapse, still Kyprolis could save the patient and could give him the benefit of a prolonged progression-free survival if used versus Velcade. How about quality of life? Yes, quality of life was much better with the use of Kyprolis versus Velcade. Now we come to the Arrow study, which is a phase 3 study comparing carfilzomib to itself. How so? Because carfilzomib in all the previous studies was to be given in 2 consecutive days. But here they are giving a higher dose, but only once weekly. So here we are comparing once weekly Kyprolis dexa to twice weekly Kyprolis dexa in the relapsed refractory setting. And as you can see here, they included patients with ejection fraction of more than or equal to 40%. And they included patients that did not have heart failure. Here, because this is a higher dose of carfilzomib, it was to be given over a 30-minute infusion. Let us look at what happened. Overall response rate was better in the once-weekly versus the twice-weekly group. And the type of response was also better with higher CRs and even stringent CRs. Remember, these are relapsed refractory cases. So better responses, better type of response in the once-weekly group versus the twice-weekly group. Not only that, but also the primary endpoint, which is progression-free survival, was significantly improved with the once-weekly versus the twice-weekly dose. This was increased, the progression-free survival was increased by 3.6 months compared to the twice-weekly dose, with reducing the risk of disease progression or death by 31%. How about the time to progression? The time to progression was longer in the once-weekly group versus the twice-weekly group, which was to be expected. How about subgroup analysis? So even in patients that had a higher stage of disease or that had a lower baseline creatinine clearance, or were either males or females, or were even more than or less than 65 years of age, progression-free survival was longer in the weekly group versus the twice-weekly group. And as I mentioned, even the higher stages at baseline of these cases responded better to the once-weekly versus the twice-weekly group. How about if patients had been exposed to transplant before, or had been exposed to previous bortezomib or lenalidomide, or even refractory to lenalidomide? Still, all groups, most of the groups, except the standard risk groups, benefited better progression-free survival with the once-weekly dose versus the twice-weekly dose. How about overall survival? Overall survival at 12 months was 76.6% in the weekly group versus 71.9% in the twice-weekly group. And so they both gave a good overall survival. And now this is our third proteasome inhibitor, ixazomib. This is the third generation proteasome inhibitor. It is an oral drug. It is to be given once weekly. And they added ixazomib to Revlimid Dexa, and they compared them to Revlimid Dexa alone, together with placebo. And this is how the inclusion criteria of the patients were. Let us look at subgroup analysis. Yes, the addition of ixazomib to Revlimid Dexa gave better results in all subgroups versus the patients that were receiving placebo with Revlimid Dexa, even in elderly patients and even in high-risk cytogenetic groups. And so, looking at progression-free survival, the addition of ixazomib to RD gave much, much better, longer progression-free survival than the patients that did not receive ixazomib. How about side effects? There were no high adverse events with the use of ixazomib that stopped the medication or the use of the medication in the study. Another drug to be used is pabinostat, and pabinostat is an HDAC inhibitor. And as you can see here, the addition of pabinostat gave better results than without pabinostat in regarding progression-free survival and in patients with relapsed multiple myeloma. Now we move to the monoclonal antibodies. And with monoclonal antibodies, they are targeting the myeloma cell antigens, and they are trying to kill the myeloma cells in different ways. For example, elotuzumab is an anti-SLAM F7 monoclonal antibody, and it elicits its effect via a dual mechanism of action, by direct activation of natural killer cell and by antibody-dependent cellular cytotoxicity. It also can affect the adhesion of myeloma cells to the bone marrow stromal cells, and so it kills the myeloma cells. And here elotuzumab was added to RD and compared to non-elotuzumab only RD, and this is the type of patient that were included, and as you can see they were relapsed refractory patients. And now let us look at the progression-free survival, and of course the addition of elotuzumab gave a much better progression-free survival versus patients that did not receive elotuzumab in the relapsed refractory setting. And here you can see the responses, and as you can see, better overall responses and regarding the elotuzumab arm versus the non-elotuzumab arm, as you can see. How about side effects? Side effects were grades 3 or 4, were not very high in the elotuzumab arm versus the other arm. Another monoclonal antibody is the anti-CD38 monoclonal antibody daratumumab, which can act on the myeloma cell by immune-mediated activity, antibody-dependent cytotoxicity, direct anti-tumor effect, and by immunomodulation and by acting on the bone marrow stromal cells. And in many ways, it can affect the complement or the macrophage or the natural killer cell and can activate them to kill the myeloma cell. This is the Pollock study, and here daratumumab was added to an IMiD and a dexamethasone. And as you can see here, there is a better progression-free survival with the addition of daratumumab in the relapsed refractory setting. How about side effects? Side effects were comparable in both arms. However, I need to point out that with any monoclonal antibody, you always look for an infusion-related reaction, and you try to avoid that by giving pre-medications with antihistaminics and corticosteroids, especially with the first dose. This is the CASTOR study, and this included cases with daratumumab in combination with Velcade-Dexa versus Velcade-Dexa alone. And as you can see, still daratumumab gave better results. And as you can see here, daratumumab gave a better progression-free survival, and it gave good results in the relapsed refractory setting. So now we mention the currently approved drugs, whether especially the proteasome inhibitors, first generation, second generation, and third generation, and their uses in relapsed refractory multiple myeloma. And as we mentioned before, the addition of a new drug, a second generation or a third generation proteasome inhibitor, gives better results in the relapsed refractory setting. Also, the use of monoclonal antibodies can be a good addition in relapsed refractory cases. And now they are thinking more of quadruplets rather than triplets, which we're going to mention later. And this might affect the relapsed multiple myeloma and make it more drug-friendly and more responding to treatment, so that we can avoid, prevent, or at least delay a second relapse. And now we are going to discuss how to choose therapy. Choosing therapy would include looking at the prior anti-myeloma therapy and response, the biology of relapse, whether it is an indolent relapse or an aggressive relapse, and whether this is a relapsed myeloma or a refractory myeloma upfront, and whether it is an extramedullary myeloma or whether it is a plasma cell leukemia, and if the patient has comorbidities, because all these will have an effect on the type of treatment chosen. And so this is a therapy at first relapse. And we look at the patient. Is he on maintenance therapy, or is the patient is not on maintenance therapy? If he relapsed on maintenance therapy, we look at the patient if he is fit or if he is frail, or if this is an indolent relapse. So if this is a fit patient, we look for a triplet including Kyprolis or daratumumab in combination with proteasome inhibitor and dexamethasone, especially if the patient is maintained on lenalidomide. If the patient is maintained on bortezomib, then the addition of DARA to Revlimid to DEXA would be of benefit. How about if this is an indolent relapse or the patient is frail, cannot be exposed to a very high medication? If the patient is on maintenance lenalidomide, then you think of DARA, VD, or you think of ixazomib in combination with DEXA and other treatments. If the patient is maintained on bortezomib, you think of ixazomib with Revlimid DEXA, or you think of DARA, Revlimid DEXA. How about the patient is not on maintenance therapy and he relapsed? It also depends if he is fit or if he's frail. If he's a fit patient, you go for Kyprolis, Revlimid DEXA, or DARA, Revlimid DEXA. If he is indolent, or if this is an indolent relapse, or if he's a frail patient, then you think of ixazomib with Revlimid, which might be of a lower dose, in DEXA, versus elotuzumab, Revlimid DEXA. How about stem cell transplant? Stem cell transplant in relapse is still an option for a selected number of patients, especially if they respond well. This is how stem cell transplant was looked at after frontline therapy in 2012. And it has been shown that with the use of immunomodulators, a delayed stem cell transplant gave almost the same percent of survival as early stem cell transplant. This is with the use of immunomodulators. How about, this was in first line, how about the use in relapse setting? Well, in the relapse setting, some of the patients can have a better progression-free survival, especially if the time to relapse or the time to another stem cell transplant would be more than 12 months after the initial stem cell transplant. And as you can see, the progression-free survival would be better if the patient relapsed late and then received, after the treatment of relapse, a second stem cell transplant. So, when and for whom the second stem cell transplant? Well, they looked at this study with relapsed myeloma post-stem cell transplant, and they, in this study, they looked to re-induce with one form of proteasome inhibitor, together with dexamethasone and maybe adriamycin, followed by a second auto versus weekly oral cytosine or endoxan. This is not a very recent study. And they looked at the results and found that in comparison to oral weekly chemotherapy, progression-free survival was better with the second transplant of 19 versus 11 months, and overall survival was better with 67 versus 52 months. And as you can see here, the use of salvage stem cell therapy gave better, in the blue line, better progression-free survival versus only weekly cyclophosphamide in the red line. And as you can see, all subgroups fared better and all types of relapse fared better with the use of salvage stem cell transplant. But who to transplant? You need a meaningful response to prior stem cell transplant, which is equal to more than 24 months without maintenance, or more than 36 to 48 months with maintenance. Probably if patients had never been having a stem cell transplant before, and this is the first one, with a good performance status, and you need plan for maintenance post-stem cell therapy. If the patient is being transplanted, you need to plan maintenance post-transplant. And be careful, stem cell transplant does not reset the disease. So how about second or later relapse? What do we do? We have to make sure that this is not plasma cell leukemia, this is not an extramedullary disease. And you look, if this is single refractory to IMiD or to a proteasome inhibitor, but not both. If the patient is refractory to an IMiD, then you add DARA together with Velcade. If the patient is refractory to a proteasome inhibitor, then it's the other way around. You give DARA together with Revlimid and dexamethasone. If the patient is refractory to dual lenalidomide or bortezomib or ixazomib, then you give pomalidomide together with DARA and dexamethasone. Or you give a carfilzomib-based approach with pomalidomide together with carprolis or Revlimid together with carprolis in combination with dexamethasone. How about the patient is triple refractory? So now he's refractory to both, to all of lenalidomide, bortezomib or ixazomib, and or carfilzomib. Then you give a pomalidomide-based therapy with DARA, pomalidomide, dexa. How about triple refractory, bortezomib, ixazomib, lenalidomide, pomalidomide? He has received all these, and he is refractory to all these, or has relapsed after receiving all these. Then daratumumab-based medication would be of best choice. You would need to think of an alkylator-based, if it works, and you think of a proteasome inhibitor together with pabenostat. And in selected patients, stem cell transplant is an option for selected patients. And of course, if patients have been receiving daratumumab with no and have relapsed, then you think of another monoclonal antibody such as olutuzumab. How about quadruple refractory disease? Patients that are refractory to lenalidomide, pomalidomide, bortezomib, and carfilzomib. You think of VTD PACE with 2 cycles, and then you think of stem cell transplant. If the patient is candidate for stem cell transplant, you go for autologous, followed by consolidation, followed by maintenance. If the patient is not a candidate, then daratumumab is your choice. Maybe pabenostat-based therapy, maybe bendamustine-based therapy, maybe an alkylator-containing combination, or an anthracycline-based therapy. How about patients with secondary plasma cell leukemia or extensive extramedullary disease, and these are not of very good prognosis? You think of giving a VDT PACE with 2 cycles, and then you think if the patient is candidate for a stem cell transplant, you go for autologous stem cell transplant, and you plan for consolidation followed by maintenance. If the patient is not a candidate, then you go still for a daratumumab-based regimen, or a pabenostat-based regimen, or an alkylator-based regimen, or an anthracycline-containing regimen. Thank you.